The initial plan was to show cases to the junior residents, but they are working right now, and unfortunately they cannot come. I changed my topic to characterization of solid renal masses. And to start, we have two busy and nice tables talking about what are the tumors that we can see in the kidneys. If you see the first table, this is from the American Registry of Pathology, and you can see I've counted that there are 45 different tumors or pseudotumors that can affect the kidneys. And obviously, it's impossible to remember that. But from the second table, this is from Radiology 2007. In this paper, the authors evaluated approximately 200 renal tumors, solid renal tumors, and they correlate the CT findings with the pathology. And what is interesting to know, if 92% of these tumors corresponded to renal cell carcinomas, angiomyolipomas, and oncocytomas, which means if we can remember and identify these lesions, we have more than 9 of 10 lesions that we can characterize of renal tumors. Let's start with the bad. For the ones that they remember the movie, the bad is a renal cell carcinoma. This is the most frequent renal tumor and account for 80 to 90% of primary neoplasms affecting the kidneys, with peak incidence in the 6th decade, and some factors that can increase the risk of this lesion. Smokers multiply per 3 the possibility to get renal cell carcinomas. Some acquired diseases like cystic renal disease can, after some time, develop renal cell carcinomas, and a lot of hereditary conditions can also affect the kidneys and develop renal cell carcinomas. The incidence increased by 38% in the last few decades, and this is basically related to the cross-sectional imaging modalities, no? And the 5-year survival rate also improved in the last 5 years, in the last few years. And when we have to talk about clinical presentation, we can say that the presentation can be as incidental finding, the one that we call incidentalomas. Approximately 25 to 40% of the cases are incidental findings. Before cross-sectional era, this was only 10%. And obviously, we have the possibility to identify the lesions with smaller size. And for us, it's a diagnostic challenge because we see the lesion, but considering that these lesions can be small and in the range of 1 centimeter or less, sometimes are very difficult to characterize. And we have to do different modalities to be sure that the lesion that we are seeing is benign or malignant. The patient can be also symptomatic. Hematuria is the most common presentation, 56%. Flank pain, weight loss, varicocele, especially the left one, can be a type of presentation. Paraneoplastic syndromes like hypercalcemia or erythrocytosis can be different ways to present the lesion. If we talk about technical parameters, we need, and this is essential for a full characterization of the lesion, to have a dedicated renal protocol. With that, we have to say that we need pre-contrast, we need post-contrast images in arterial, venous, and delayed. Pre-contrast images, basically for measurement of the lesion and see if the lesion enhanced after contrast administration. Also for evaluation of calcifications and for evaluation of fat. After contrast administration, we have the corticomedullary phase, which is a phase ranging from 35 to 40 seconds, and is usually useful for evaluation of vascular structures and also for identification of secondary lesions. Remember that renal cell carcinomas can produce hypervascular secondary lesions in the liver and are very well visualized on our early phase. Nephrographic phase is the best phase for identification of the renal mass, and this is a paper published in Radiology in which they compare the different phases, pre-contrast, corticomedullary, and nephrographic phases, and you can see in nephrographic phase you can identify the largest number of tumors, 295 tumors, compared with corticomedullary phase only identified 211, and pre-contrast phase only 94 cases, 94 lesions. The excretory phase is useful for evaluation of the collecting systems. And let's see some examples. Yeah, we have different phases in this case. We have the pre-contrast and the corticomedullary phase in a patient with a right renal mass. Obviously, if we have only these images, it will be difficult to characterize, identify, and delineate the lesion, but if we do the nephrographic phase, we can see how delineated is the lesion, and this corresponds to a renal cell carcinoma. Histological types. Is it important to know what type of lesion we are seeing? Yeah, it is. Because, for example, in renal cell carcinomas, depending on the histological type, the enhancement of the lesion can be different. The most common histological type of renal cell carcinoma is clear cell with almost 80% of the cases, followed by the papillary renal cell carcinoma, 15%, and then between chromophobe or sarcomatoid, not sarcoma, this is a carcinoma with sarcomatoid features, in about 5% or 6% if we count both. How is the appearance of the lesion? 95% are solid, 5% are cystic, and in this 5% is when we apply the Bosnia classification. But keep in mind that renal cell carcinomas are most of them solid, well defined. If small, can be homogeneous. If these lesions are larger than 3 centimeters, usually are heterogeneous, and this is due to high vascularity of the tumor, developing areas of hemorrhage and necrosis. Calcification, that's important to remember that. When we talk about histological types of renal cell carcinomas, papillary renal cell carcinoma can calcify in 30% of the cases. Clear cell does not calcify. The infiltrative pattern is very rare, and the diagnosis, the differential diagnosis, when it's present, we have to consider sarcomas, lymphomas, and metastases. What are the parameters that we use for characterization? One of these is the tumor enhancement. And there is some debate about tumor enhancement should be considered in 15 Hansfield units or 20. In the last few presented publications, 20 is what we are considering now. And keep in mind that the clear cell is very vascular, it's a hypervascular tumor, and the papillary type is hypovascular tumor. Saying that, we have two features typical of papillary renal cell carcinomas. One is hypovascular compared with the parenchyma, and the other one is calcification in 30% of the cases. I talk about enhancement, and if we consider 20 Hansfield units as the change in Hansfield units to consider enhancement, we have to say also that most of the tumors, solid tumors in the kidneys, are in the range of 40 Hansfield units. This is pre-contrast. Look at here, these are renal cell carcinomas, clear cell, chromophobe, and papillary, and this is the oncocytoma, the other type of tumor that can affect the kidney, and angiomyolipomas. I said that considering all these, we have 92% of the tumors affecting the kidneys. Okay. More or less, there are the Hansfield units are 40 Hansfield units. When we put contrast, and this is important to see, the tumor that gets less contrast is the papillary type. But it goes to 80, which means at least we have 40 Hansfield units of difference between pre and post, which means the problem of pseudo-enhancement usually is not common in renal cell tumors. Okay? What is the tumor with the highest enhancement? Is this one. This is the oncocytoma, and is followed by clear cell carcinoma, then angiomyolipoma, then papillary type, and the last one, then chromophobe, and the last one papillary type. Examples. Look at this patient, pre-contrast corticomedullary phase and nephrographic delayed phase, in which we have a rounded, well-defined lesion in the anterior aspect of the left kidney in the interpolar region. This is the typical pattern. Probably a couple of centimeters tumor, heterogeneous. I said that this heterogeneity is likely related to hemorrhage or necrosis. This is the typical pattern. This is the same tumor. Look at the areas of hemorrhage. This was a clear cell. Which one is this one? Ibrahim. It's a solid tumor, but it's hypodense, hypovascular, and has a feature that I mentioned, typical of what? Look at this. What is this? Calcium. Calcium is in papillary type. 30% of papillary type have calcifications. And this is a typical pattern, lower density than the parenchyma, than the normal renal parenchyma, and is well defined. And this is the gross of the same patient, and look at the calcifications in the periphery. I said that the one of the rare types of renal cell carcinoma is the carcinoma with sarcomatoid features. These tumors are usually ill-defined. And this is one example. If you want to delineate the tumor, it's difficult, and you can see how aggressive it is extending into the retroperitoneum, extending into the vascular system, and causing a lot of lymphadenopathy in the periaortic area. The staging of renal tumors, we consider TNM. For T1 are tumors 7 centimeters or less, and you can divide that in A or B if it's up to 4 or more than 4. T2 is 7 centimeters, limited to the kidney. T3 are tumors extending into the major vascular structures, adrenals, perinephric tissue, but when the tumor does not go through the Gerota's fascia. T4 is when the tumor invades the Gerota's fascia. For N, we have N0, no regional lymph nodes involved, N1, a single regional lymph node, and N2, more than one. And obviously M is M0, no metastasis, M1, distant metastasis. Let's see some examples. The tumor extension is the most important factor to determine prognosis at time of diagnosis. And look at this. This is from the American Cancer Society. You can see different type of malignancies, but the kidney, look at the difference between local staging or local extension and distant disease. It's ranging from 90% to only 10%. It's very important to have early stage, and we said now with cross-sectional modalities, we have patients asymptomatic in up to 40% of the cases. Renal cell carcinoma T1B, we said is between 4 to 7. This was a clear cell in the inferior pole of the right kidney. Nephrographic and delayed phases are showing a very vascular tumor, well defined without compromise of the perinephric fat, renal cell carcinoma. Another example, T1A, less than 4 centimeters, similar imaging pattern, well defined, confined to the kidney, minimal fat stranding, and this is the example of the other side of the cone. A T4 patient in which you can see the abnormalities in the IVP. We have a normal right kidney, but the left kidney, we can barely see the margins, especially the upper margin, and look at how distorted is the collecting system. This is the pelvocalyceal system with a lot of filling defects and dilatation. This is the example. It's the same patient, and I said that a diffuse pattern is rare but can be possible, and this is one of the cases. You have an extensive tumor in which the margins are lost in most of the kidney. We can evaluate the amount of collaterals developed by the tumor, the angiogenesis of the tumor, and also we can say that this is a type 4 because it's affecting the gyrotous fascia. This is the same patient, coronal reconstruction, affecting the perirenal fascia, and this is the surgical specimen. I said that when we have perinephric involvement is T3. Sometimes we can overestimate or underestimate fat compromise. And this is because the fat stranding is commonly seen even in normal patients. If any of us get a CT, we can probably see the perinephric fat stranding. But what we have to consider in patients with tumor is the nodular fat stranding. The one that we can see not only these linear, normal appearing septations around the kidney, especially in the posterior perinephric space, posterior aspect of the perinephric space. What we have to look for is this nodular pattern. If the nodular pattern is present, the specificity is high for invasion of the perinephric fat. Let's see examples. You see, we have a tumor in the lateral aspect of the right kidney, and we can see at least 3 nodular appearing abnormalities in the perinephric fat, and this is compatible with invasion of the perinephric space. This is another example. In this case, we said that if there is invasion of the collecting system. In this case, we have an extensive tumor affecting the right kidney, with invasion of the collecting system and also with invasion of the ipsilateral adrenal. We can see the tumor, how it extends into the collecting system with a crescent-shaped filling defect in the proximal ureter and the renal pelvis. With the CT, we can create all these fancy reconstructions simulating IVP, and we can see how the right-sided collecting system is irregular with areas of non-opacification, and this is related to compression and invasion from the adjacent tumor. Venous extension, we have to remember that 23% of the renal cell carcinomas are going to renal veins, and the CT can can identify this abnormality pretty high. And the invasion of the IVC is 4 to 10%. When we have the tumor going into the vascular structure, we have some features that we have to look for to differentiate from a blunt thrombosis. Usually, these tumors going into the IVC are in the lumen, not in the wall of the vessel. We can see abrupt change in the luminal caliber. We can see heterogeneous enhancement, and also the presence of collateral circulation. Let's see some examples. This is a left-sided renal cell carcinoma with invasion into the left renal vein and the IVC. We can see the margins, and we can see how heterogeneous is the filling defect. This is a tumor thrombosis. Another patient with extensive tumor thrombus involving the IVC in a patient with acquired renal disease and development of renal cell carcinomas. In this patient, we have two different tumors, one in the upper pole, the other one in the interpolar region, and the second one is the one invading the IVC. This tumor is also to show how is the vascularity of the tumor and how can the tumor develop collateral vessels to supply the area. Lymphatic extension, when it's present, lymphatic involvement at time of diagnosis is not a good sign, and usually the survival rate decreases to 60% from 90 to 60. What we evaluate is the morphology of the lymph node with a transverse caliber that shouldn't be more than 1 centimeter. And usually there is a very good correlation between the size of the lymph node and the involvement of of these nodes. This is just to show the kidney and the perinephric space. We have the perinephric space surrounded by the gerotas and the Zucker candle fascias. These are the Kunin fascias, 3 types: renofascial, fasciofascial, and renorenal. And we have also to remember that we have arteries, veins, and lymph nodes. These lymph nodes, what are when the tumor affect the kidney, can disseminate the process into the retroperitoneal perivascular nodes: intercaval aortic, retroaortic, retrocaval, or precaval and preaortic, depending where is located the tumor. Examples: large tumor, right kidney, a lot of intercaval aortic lymphadenopathy with necrotic changes. If we talk about metastasis, we have to say, depending on the tumor, the size of the tumor, the incidence is different. If the tumor is less than 3 centimeters, the incidence is around 2%. If it's more than 5 centimeters, the incidence is close to 80%. Metastases are going to lungs, liver, bones, contralateral kidneys, and adrenals. One example, in this case, we have direct extension of the tumor into the spleen, and also a left hepatic lobe secondary lesion. One thing to mention is the metastases going to the bones. How are these lesions? Typical lytic lesions, pure lytic lesions. This is the typical pattern, lytic lesion with soft tissue component, no sclerosis, and it's important to highlight this because bone scans are not helpful at all when you want to evaluate these lesions. Okay. Renal cell carcinomas containing fat. The lesion that contains fat, the most common one containing fat, is the angiomyolipoma. But renal cell carcinoma can contain fat in several, not several, but in few cases. Different causes, and the tip for diagnosis is to check if there is any other calcification. And why is that? Because angiomyolipomas does not calcify. If you have fat plus calcification, can be a papillary renal cell carcinoma. The areas of fat compared with the rest of the tumor. If these are very small, can be renal cell carcinomas. And if you have any doubt, you can do CT histogram analysis and check if there is any area of the tumor with fat density. We'll see later some examples. Another association of tumors are hereditary conditions, and we have a large list like von Hippel-Lindau, tuberous sclerosis, hereditary papillary carcinoma, and familial oncocytoma. Usually, these tumors are multiple and bilateral with earlier presentation than isolated renal cell carcinomas. We said in the 6th decade. Usually these tumors are between the 4th and 5th decades. And early screening is suggested for these patients. Von Hippel-Lindau is associated with renal cell carcinomas, and between 25 to 45% of patients with von Hippel-Lindau can develop a renal cell carcinoma. 75% are bilateral, the peak, as I said before, between the 4th and 5th decade, and there is also association with renal cyst and oncocytomas, but keep in mind the tumor which higher association with von Hippel-Lindau is the renal cell. Let's see this example. Patient with multiple bilateral renal lesions, some of them cystic, some of them solid. If we consider the cystic is also is a complex lesion, and these were renal cell carcinomas. Let's see some benign renal masses. Oncocytoma is a benign neoplasm, very uncommon, between 3 to 7% of old adult renal tumors. 75% of the cases is an incidental finding, and unfortunately the diagnosis is, most of the cases, diagnosis is made with surgery, because the pattern is so similar to the renal cell carcinoma that we cannot be sure that we are in the presence of oncocytoma. Let's see some examples. The images are well defined masses with an average size of 6 centimeters, is heterogeneous and hypervascular, and in 30% of the cases contains the central scar. This is a typical example of oncocytoma. Remember, I said oncocytoma is a vascular tumor. In this case, we have a heterogeneity and hypervascularity with a central low density focus compatible with the scar that I mentioned before. The problem of this most of the tumors or oncocytomas are not showing this pattern. If you have this pattern, probably you suggest oncocytoma over renal cell carcinoma. This is another example. Look at the pattern. Heterogeneous, well-defined, hypervascular. If I tell you that this is renal cell carcinoma, it can be true. Angiomyolipomas is also uncommon. It's a combination of fat, muscles, and vessels. That's why it's so heterogeneous. Most of them, the diagnosis is incidental. 80% are isolated lesions and 20% are multiple and associated with hereditary conditions such as Ibrahim? Very good. Very good. Okay. This is very easy to diagnose when you have macroscopic fat. You have these combinations of structures. I told you muscle, fat, and vessels. If you have fat, macroscopic fat, this is angiomyolipoma. That's it. The problem is when the fat is not detected macroscopically. And you can have angiomyolipoma with the predominant component of vessels and muscles, and you don't see the fat, and most of the time the diagnosis is made on pathology. But this is very uncommon presentation. Let's see some examples of typical angiomyolipomas. CT on the top, MRI on the bottom. We can see pre-contrast arterial and venous phases, the area of fat. No doubt this is angiomyolipoma. If we do the MRI, we can do in phase and out phase sequences with drop of the intensity signal. We can do fat saturation sequences also, like in this case, the last one, which there is hypointensity of the area of fat. Another case with tuberous sclerosis. In this case, we have the angiomyolipoma and also multiple lesions in the liver consistent with lipomas. Also a lesion in the proximal pancreas. Sometimes benign tumors can invade surrounding structures. Like in this case, this is a very uncommon presentation, but I would like to show you this case. This is an invasive angiomyolipoma. Look at the density. No doubt that this is a mass containing large amount of fat, and how the tumor extends into the renal vein and a little bit of IVC. We measure the fat, look at the reconstructions, how the tumor goes into the renal vein, and this is the specimen with the fat containing mass plus the extension into the venous system. Angiomyolipoma and tuberous sclerosis. Another example, multiple tumors, bilateral, renal tumors, but if we pay attention, all of them are showing a different degree of fat. Same patient, different multiplanar reconstructions in corona and sagittal. This patient also show hepatic lipoma. And let's see some other tumors or pseudotumors simulated malignancies. The first one is what we call pseudotumor. These are congenital or acquired abnormalities that may be described as malignancy. One of these is a hypertrophy of the columns of Burden. That's congenital. Acquired can be hypertrophy of a normal tissue adjacent to an atrophic kidney. to a scar, and I will show you an example later. What is this? These are 3 planes of the left kidney, axial, sagittal, and coronal, showing hypertrophy of the column of Bertin. This patient came to CT with a question of a left renal mass on ultrasound. Another pseudotumor, I said, that can be hypertrophy or focal hypertrophy of the kidney, and that's what happened in this patient. We have a trophic kidney with an area of probably asymmetric vascular supply, you know, keeping part of the kidney with normal caliber. This was proven as benign. Talking about pseudotumors or lesions simulating a solid mass, we have the hyperdense cyst. Look at that. We have the precontrust phase, first column, corticomedullary and delayed phase. In these phases, we measure the density of the lesion. If we don't have the precontrust phase, it's very difficult to tell if this lesion is cystic or solid, because we are measuring 87 Hansfield units and 89 Hansfield units. But if we have the precontrast phase, you can see that the lesion measures in precontrast phase 80 Hansfield units. No doubt, no more questions, this is a hyperdense cyst. Why a cyst can be so dense? Because it contains hemorrhage or proteinaceous material. That's why it's very important to have a full protocol. Few words about renal lymphomas. Renal involvement in patients with non-lymphoma ranges from 30 to 60%, but the primary renal lymphoma is rare. There are different presentations for renal compromise, and the one that I would like to discuss is the one that is a focal, well-defined lesion that can simulate any other type of tumors. And in this type of tumors, in lymphomas, or sometimes when we suspect metastasis, is in the case that a biopsy can play a role. Usually we don't want to make any biopsy for diagnosis of renal cell carcinoma. If the image is compatible, what is the next step? Surgery. There are 2 places in which a biopsy can be a next step. One of these is lymphoma, the other one is metastasis, because obviously you don't want to operate a lymphoma and you don't want to operate a metastasis. You want to treat medically. These are the different patterns: single mass, multiple masses, 60% most common type, invasion from continuous retroperitoneal disease, perirenal disease, and diffuse renal infiltration. Let's see the one that is a solitary mass. Usually renal lymphomas are hypovascular lesions. The margins are not well defined, like in this case in the left kidney, in the left kidney. These are also well defined but multiple. Look at the pattern of the lesion, low density, bilateral. Differentials can be metastasis. Okay, finally, as a conclusion, we had to say that MDCT is the most sensitive and efficient examination for evaluation of the kidneys, and is the modality of choice in most, if not all, renal masses. It's excellent to differentiate surgical from non-surgical renal conditions. It's the imaging modality of choice for staging, and except For specific cases, the use of IV contrast and a dedicated renal protocol is mandatory. And I think this is the last slide. Thank you for your attention.